I'm Dr. Rick Greene from the medical school class of 1970, and it's my great pleasure to be the moderator of this series honoring our noted emeritus professors at the University of Virginia. Today, it's an equally great pleasure to talk with Dr. Tom Daniel, who's a surgeon. I'm a surgeon, and so it's great to have a surgeon to chat with this afternoon. And Tom, thank you for spending the time with us.
You're very welcome.
Basically, what we're doing this series is really just to get your vision, your ideas about being at Virginia for a number of years. First thing I want to ask you, though, you were in the Navy.
I was.
I was in the Navy. You were a submariner.
Oh, you've done the work.
I was on a carrier. So I want to ask you...
You're the bad guy.
Perhaps. I want to ask you about the influence of military career, military life. You know, you were at a naval hospital in Charleston. You were at sea for a while. How did that affect your career?
Well, first of all, just putting in time in the military as an obligation as a citizen meant something to me then, and it's increasingly meant something. I served my time, and it exposed me particularly after the experience you had, intense pre-med, intense med school, intense residency, to be with other people who didn't speak that language. Fascinating guys from the Naval Academy, NRTC programs, enlisted men, getting to know them, and you get to know people pretty well if you live in a 400-foot space for 2 months at a time without surfacing. That's a chance to get to know people. And so I would say that it exposed me to a lot of different kind of folks with different ambitions and values that I probably never would have seen if I'd stayed in that intense surgical medical training route. Much the same as someone after college nowadays increasingly will go do something in the world, a job, something else, before going to med school. I think it just gives you a dimension that you don't get when you stay in the trenches going through a professional preparation.
It was sort of your gap years, as the kids call it today.
Yes.
The gap years.
Yes, I think it's very important.
Did you give any consideration to staying in the military?
No.
No.
I enjoyed it, and I still have some friends from that time. But no, I was eager because I was just in the middle of my training.
Right.
I hadn't completed my training. In fact, I left. I went to UVA as well, graduated in the class of '64, and left not sure. I liked both internal medicine and surgery. And so I made the decision, if I was going to choose one or the other, choose medical residency, because if you're a surgeon, that wouldn't hurt you. Whereas if you start surgical residency and then go into medicine, it's not the same kind of full background, and it worked out very well.
Right. So I was going to ask you that when you did the 2 years, I think, in internal medicine, with the idea of going into surgery, or were you going to stay in medicine?
In my first year of medical residency, what we used to call internship, I pretty much found myself hanging around the OR, going to surgical conferences. There was a very dynamic surgeon at Boston University Hospital. Actually, he was from MCV, a guy named John Manick, who had just come in, and he was just full of energy, and I just said, you know what? Internal medicine's fun. I like the diagnostic part of it, but the chance in surgery to operate and to make decisions quickly was very appealing to me, and so I pretty much decided after 1 year. Then I had to wait a year to go into the military, so I went and took a second year at Emory Hospital, run by Willis Hurst, who was just an incredible diagnostician as well as a world-famous cardiologist. So I had a real dose of diagnostic experience, patient evaluation, and then I had my military time, as I just talked about. And during that time, I was able to apply to surgical programs and got into the Duke program and spent 7 years there going through their system.
So it brings up the whole concept of mentorship. You mentioned John Manick, you mentioned Dr. Willis Hurst. We both had a common mentor, George Minor.
Oh, yes.
And I want to ask you about your relationship with Dr. Minor. I mean, obviously you're a thoracic surgeon. He was a thoracic surgeon. Give us some of your remembrances.
Well, it's interesting. I was thinking about role models. I enjoyed knowing Dr. Minor as a medical student. but I was more drawn to the personality of Harry Muller. His rounds, his excitement working in an area of cardiac surgery that was really developing. And so it was a high-risk game with a lot of intensity. He was more my mentor. I knew George, loved his idiosyncrasies, his interest in cooking and things outside of medicine, and his ability to tell wonderful stories. But it's interesting, in medical school, he wasn't anywhere near as strong a mentor as Dr. Muller. Now, when I finished training at Duke, I went into private practice in my hometown of Richmond for 9 years. Had a wonderful group of guys I was working with. But what ultimately led me to come back into academics, George was a part of that, because he had kept the thoracic surgery program going, and when he retired, serendipitously I happened to be coming back to UVA to meet some friends, and next thing I knew, I was interviewing with Dr. Miner. I'll have to tell you this, my first interview with Dr. Miner, having been in private practice, I studied up on everything general thoracic that I could think of, so I could be really up to date on treatment of tuberculosis and all the medical, surgical issues that make general thoracic. And I walked into his office, and he greeted me nicely. He remembered me from my med school days. And he threw this book across the table and said, "What do you know about this?" And I picked it up, and it was a book on Thai cooking. So he was a real character. I did not have much knowledge about Thai cooking, but fortunately, convinced him that I did have enough knowledge of thoracic surgery.
So the combination of being in private practice and then gravitating to academics, I did the same thing, so I understand what you have done. How did being in private practice help you in your academic career?
Oh, immeasurably. I think when you come into academics, through academics, no matter how hard you try, you never are as aware of the patient and their family. In some sense, I've felt that sometimes people think people always come to the university because it's a great medical center, but they don't realize the role of your relationship with the patient's family and with them, what that might have with your career. So I saw time and time again situations where being in private practice, knowing the importance of greeting the family, I had learned that actually from Dr. Beckwith, one of my role models, Julian Beckwith. He was a cardiologist when I was in med school. He was a great cardiologist, but more it was his approach to the patient. I'll never forget, he said, when you first meet a patient, you want to say, well, tell me what's wrong with you, or what are your symptoms? He said, take a second. Look at him and say, where are you from? And he said, it changes the whole subsequent interview. Hopefully it's a genuine question on your part, but it tells them you're interested in them as a patient. And it not only makes them feel more comfortable to you, but they're more likely to open up and tell you more of their symptoms, maybe their sexual history, maybe their emotional history, that you never would have gotten if you'd come in and said, now tell me what's wrong with you, where do you hurt? And little things like that, he emphasized the importance of sitting at the level of the patient when you come in a room. Don't stand up with your arms like this. Sit on a bed, sit on a chair, perhaps even reach out and just feel their pulse. It sounds corny, but it isn't. It's a part of that initial patient interface that I think has made, even in academics, and it's not just something you're doing for the patient. I can tell you, after years of practice, and I'm sure you've experienced this, you're getting to know patients and remembering this character from Pulaski or that person who had an interesting hobby or this, makes your practice more interesting over the long run when you've been doing it for decades. Just knowing the personalities behind the patient, I would say it's very much in your interest to stay active emotionally and intellectually in your practice.
Well, that's a great segue, because the term emeritus, of course, is an interesting term. It doesn't mean that people aren't doing things in medicine and aren't doing things that are important. What are you doing in medicine today?
In the big world of medicine?
The big world of medicine, not necessarily being in the operating room, but what are your interests? Do you still have interest in what's going on in medicine?
I do. When I first retired 8 years ago, I sort of want to get as far away from being on call 24 hours a day, doing a transplant all night, and then seeing patients all the next day. I thought, okay. But like a magnet, it has drawn me back. And I found myself now involved for now going on 7 years with a quit smoking group over at our free clinic.
Excellent.
I got interested in that as a thoracic surgeon, just what it takes to get people to try to quit smoking. And it certainly isn't expertise on my part or the fact that I'm a lung cancer surgeon. It's much more like AA. It's getting a group that the person feels someone cares about them, and using every little option for how to quit smoking. In our group, we have acupuncturists come, we have a mindfulness program, we have a weight management program, of course we have a program on pharmacology of quit smoking, but it has been just a fascinating experience. And in addition to that, I've in the last 3 years, with my good wife's help, I've actually spent 5 months in Rwanda, Africa. Not just teaching general and thoracic surgery, but taking over there a way of learning surgery that I think might help countries without many resources and who have the problem of trying to speed up their training to try to catch up with healthcare requirements. And that is use of simulation surgery. So I went to a course in Chapel Hill run by a friend of mine, Rick Fines, who emphasizes that for folks in North America. But I thought, if you could take simulation models that are cheap to make out of materials that are available in the third world and teach them using models you make at home and then use tissue from animals over there that are sacrificed for meat, and you could get the heart, lung, and abdominal contents, and set up models where you could train a resident in one morning 10 different operations that it might take them a year to see. And so that has been my passion the last couple of years. And 5 months over there, and then most recently I invited the chief of surgery from one of the university hospitals in Rwanda and a very smart, rising, enthusiastic resident that I taught to come here to UVA and meet my colleagues, do some more simulation surgery here, get to know the Center for Global Health, which is an incredible resource here at UVA, and also participate in a project I had to embellish the simulation surgery in third world, and that is create a website with a very exciting company here in town called Cyten that specializes in internet learning. And I put the entire manual that I wrote for my simulation surgery course on the web now. And now it's available to anybody in the world for free who wants to get a head start in simulation surgery to see if it might help them in their program or help them in their training, learn a little bit more about surgery, and perhaps even to stimulate some medical students and residents in their training to go into surgery.
Well, I'm very aware of the program at UVA and obviously your involvement in the Rwanda program, and I want to salute you. We've been talking with Dr. Tom Daniel today, not only a wonderful thoracic surgeon, but also an alumnus of the University of Virginia. Tom, thank you for being with us.
My
Really
pleasure.
appreciate it.
Enjoyed being here.